So what I want to do is I'd actually like to go kind of down the line and just ask the simple question of anterior approach. I mean, we just kind of seen where it's come over the last 20 years. What are the barriers to it moving forward? What are the things that need to change? What are the key problems that we need to solve? And I think we can go down the line. Start with you, Kristoff.
The barriers? Well, maybe I pass it on to you first, because I have to think a little bit about it.
Yeah, it's a lot easier to talk about the things that we have made progress with because the list is so long. In my practice, when I think about things that I still think about with outcomes with patients, the lateral thermocutaneous nerve, we all poo-poo it and write it off, and I've published our results with it. I mean, it's an issue, right? It is. I mean, typically it's just some numbness, and it's not that big of a deal. But a lot of people will say, hey, doc, when will this get better? And I think the key with that is educating people. And I tell everybody, it's a 50% chance it goes out, and in all likelihood it won't bother you. And a very small percentage of people, it does bother them. And so I think education and keeping folks abreast of that ahead of surgery is a key part of that. But I don't know if there's a way to do this aside from moving the incision in a creative way somewhere else to stay out of that network. But that's one thing that it's hard to totally fix.
What kind of incision do you use?
All of them. So bikini, longitudinal, and for a while I started doing a Watson Jones to see what would happen. And those people, so I would just, same exact approach, same instrumentation, but just go behind the tensor, and they don't get it. And the exposure is a little tougher, and I don't like being right on the anterior margin of the medius because it's the one that's going to get beat up if you're doing something. And so a lot of people shy away from that. But the Japanese just published a study looking at the normal DA incision versus an incision that's more posterior and goes in the interval behind tensor, between medius and tensor. And they don't have a whole lot of LFCN symptoms. In fact, they had none. And then the anterior group had the numbers that we all talk about.
Yeah, they probably ought to check innervation to the tensor, though. I think that superior gluteal nerve is pretty sensitive to stretch because, you can, and I think some of with the Harding lateral approach, it was always talked about that, we detach part of the tendon of the abductors so they get abductor weakness. I think probably a fair amount of the weakness was superior gluteal nerve stretch, though, too. Because you can even see, like, as sensitive as the lateral femoral cutaneous nerve is, that you go to the internal iliac fossa and take a bone graft, and people will end up some lateral femoral cutaneous deficit just because you put pressure on it or a little stretch. I would suspect the same thing's happening with the superior gluteal nerve a lot of time that's not realized. Posterior approach damage to superior gluteal nerve, too, is people try to elevate proximally in revision surgery.
I guess that's my question to the panel. Have you guys changed anything in terms of technique to try to decrease your LFCN? Am I the only one in the group that has about 50% of my people say I at least know that there's an issue there?
If you look at the data, the incidence is high. I mean, in Lunix, it was almost 60%. It's not minimal, and people would quote 10%. I just undermine the sub-Q tissue a little bit less, but sometimes you're just staring at it right there.
Yeah, I don't hear my patients complain much, but maybe I'm not listening or seeing them enough. I get a lot of patients come to Vail from out of town.
Maybe that's my problem. I should stop asking and listening.
You stop listening.
The complaints are unusual, but I would expect that if you carefully examine everybody, I mean, if you did a 2-point discrimination stuff, you're going to find something with everybody, but we don't really know the incidence with other incisions, too. The way Jonathan, that Urosimides talks about it, too, is when he hears people talk about complication of anterior approach with sensory loss of lateral femoral cutaneous, he said, well, then every total knee that's done has a complication, a neurologic complication. So it's, because every total knee incision, lateral to the incision, they're getting numbness.
I want to bring up Kristoff's talk. I mean, I think that was a profound talk on the TFL. When I think about my patients, a lot of them have a weird swelling on the anterior thigh. I mean, probably most. Now, I only look at it when they ask me to look. And it is. A lot of patients have this. So I think you're spot on. I think you're absolutely onto something with this TFL. You know, once you start learning the anterior approach, you just don't want to bugger up the TFL, right? You just don't want to cut it in half or with your reamer or, you know, whatever. You know, when we have our early learning curve, those TFLs get buggered up easy. Once you start really appreciating the approach, then that's easy to deal with. But now I think we have to, you know, really look at what Kristoff's taught us here, right? So I'm treating my incisions more and more and more proximal. I love the interval we're at, and I'm going to have to deal with this nerve issue for sure for the rest of my career. But I love the interval we are. I think we have to carry it more and more proximal. As we carry those incisions more proximal, I've got a better view of the femur, and my concept of exposing the femur has changed so much, right? We used to think we had to really get that femur to pop out of the wound, and I like to leave that thing be, right? I want to leave all this rotators, all the capsule be. So I think this concept of sparing the vessel is a cool idea. I think the idea of sparing more of the capsule is a cool idea. I mean, right now, I release the heck out of my capsule, right? I almost do like a 270-degree release of that capsule. If we carry it more proximal, can we avoid that and come almost from a top-down approach in the same interval? I think so. For me, that's where I want to take it. I want to carry it more proximal. And for me, that's where I think I want to go.
But Kristoff, you were saying that 60% of the time you saw that vessel rupture during the case. So are you executing what you want to execute?
So my main message was the vessels do rupture, and that means that the theory of the devascularization could be an issue there. So what we will now do is we will try to do the vessel sparing procedure. We see, is the muscle ruptured, yes or no? What does this mean for the, is the vessel ruptured, yes or no? What does it mean for the MRI? But second, and that is what we also see, the fascia innominata remains intact. And I think that shift, it's a little shift. It's not always there, and we see it in females. And if we really look at the most difficult population that we are faced with, it's female patients. They are most sensitive to this periarticular muscle pain. So we did an assessment of about 1,000 anterior approach patients, and we looked not at the revisions that we had to do, but we looked at how many of these patients have a forgotten hip. Do you have any idea how many of our patients had a forgotten hip trajectory post-op? I'll tell you, 80%. So 20% of our patients do not have a forgotten hip trajectory post-operatively. And we have to be honest with that. That is, in my opinion, the missing link that we have to understand. Why is this? We recently published a paper on psoas tendinitis post-op, 2%. 2% of our patients have a transient psoas tendinitis. And you know what? The main factors for psoas tendinitis were, so this is psoas tendinitis that occurs 3 to 6 months post-op. 3 to 6 months post-op. Well, lumbar spine fusion was the #1 prognosticator for post-op psoas tendinitis. And it all makes sense because we no longer flex that spine. And the second one was dysplasia. And the third one was failed hip scopes. I think what we need to do is, if we want to innovate anterior approach, and anterior approach without any doubt is the most muscle sparing procedure, and we have to look at the hip joint in 3 segments: the spine, the pelvis, and the upper leg. That's the hip joint. It's no longer a ball and socket joint. Now the question comes, how can we make sure that this alignment improves post-operatively? That is why these patients develop this kind of transient pain.
The big attraction for anterior approach for most of us is not because we don't cut muscle or because of the interval or anything like that. It's because we've used fluoroscopy or some kind of technique that's much easier to do with a patient laying supine, right? And the thing that we don't appreciate is femoral head center, native hip centers, right? We had some great talks on resurfacing yesterday. Right? There's something to this resurfacing thing, and it may be hip centers, right? It may be that we're just medializing the heck out of these like John Charnley taught us to, and that may not be the right answer. We may need to keep our hip centers as native as we can. We may have to rethink how we think about total offset, right? For me, I drop down my offset significantly, so my total offset is almost always reduced. And I like to preserve my femoral offset, but I may be way off on this. But I think, we should pay attention to this resurfacing literature and re-question how far we medialize these cups, because it may affect these forgotten hip scores.
Yeah, I think we've, with the innominate fascia, I mean, it's a good point to think about, but one of the reasons probably from the beginning we have cut it or we have released it is that to get a better side-to-side mobility of the tensor. So you can run into the problem if you leave it there and you don't release it at all, that you're pulling very hard on the tensor and you start to get damage to the muscle. And that's just a principle of surgery, is make the incision long enough you don't have too much tension on soft tissues. But I think, as we look at the results of anterior approach, like the incidence of forgotten hip, I think it's probably much higher with anterior approach than it was with posterior approach. And so we realize we aren't perfect yet with the soft tissue, and every time I talk to a patient, talk to them about an operation, a phrase I often use is that every surgery takes a little bite out of you. It doesn't matter what it is, but I tell them, you have a car, it's made to come apart, go back together with fasteners. If somebody screws it up, your car repair, somebody can put it back to as new condition, but the human body isn't like that. So it's hard to do that, make invasions into the human body, come out again and not take a bite out of somebody. And that's probably why our main goal here is not to do revisions great, but to make the best primaries that last the rest of people's lives so you don't take a bite out of them. One phrase I heard today, and I think it came from a Steve Jobs quote that maybe I'd leave as a passing thought, is a technology, and I've been in favor of developing technology, I've worked on it, but is the technology useful to the user or something the user wants, So we can see it at this meeting too, where there's a proliferation of imaging and guidance and robotic arm and everything, but it'll have to get sorted out, and it'll get sorted out especially by the market, I think, which technologies actually are useful, which is another step that's going to take time, or some machine sitting in the way everybody's stumbling about. So it'll be interesting. I don't think surgical skill and experience is dead, and particularly when you talk about efficiencies, bringing in some machine to hold something, well, I can take it in my hand here sometimes. So the market will determine it as we go forward, I think. So I think everybody had a chance to make a comment. And for just next year, we're planning, we don't have the hotel nailed down, but the tentative plan was to do this in Nashville, Tennessee. We're just going to go a little closer to the East Coast, maybe have a variety. We're thinking around third weekend in May we might be shooting for, so enjoy the rest of the trip in Vegas. Thank you.